now's an opportunity to ask questions, even if it comes out of left field, or to pick up on what's happened so far. So our three experts are the man with the nice jacket, David Gleeson, the lady with the matching jacket, Catherine Smith, and Lucy, who isn't wearing a jacket. So Lucy is a new trustee of the Psoriasis Association, and Lucy is also nurse consultant at St John's, and looks after patients with a host of skin problems, including psoriasis. And she's often the first point of call if there is a problem. So when we were talking about you want easy access to advice, it's usually Lucy who's giving it in our service. And she plays an absolutely crucial role in keeping the show on the road, and indeed actually hopefully keeping our patients with psoriasis at home and happy with the treatment by dealing with all the issues that come up. So if fire away with any questions. Got two hands already, excellent.
So apart from all the medication that you've mentioned, what are your thoughts on alternatives? So aloe vera, sea moss, the sunshine, things that are sort of not medical, the medical model, but alternatives. What are your views on those?
Lucy, do you want to say about it's holistic care, isn't
Yeah,
it?
yeah. So I think obviously, I think it depends on what you've mentioned a lot of things there. So stuff like aloe vera, I think with things like that, if you wanted to use, say, an aloe vera cream for your skin, I mean, obviously we typically would recommend very bland emollients. But if there is a product that you want to try, then it's worth doing a test patch to see if it can help. Things like sunshine, we know that helps psoriasis, but that can also increase your risk of developing some skin cancers as well. But there's definitely a place for things other than just medicine in terms of keeping yourself healthy.
I think Tivi actually
it
had a very nice visual about that, that it's not either one or the other. So I think that, I suppose what for me when I'm speaking to patients, I would always want to get the best treatment, and I think so there is a lot of alternative therapies there which really are unproven, and people have a perception sometimes that an alternative therapy is safer and better. So I think, and if a person's got bad psoriasis and they need treatment, and I've got a treatment that I think is safe, and I know it's safe and it's effective. So I think that it depends completely on what the alternative therapy is, but I think there's lots of room for aligned complementary strategies that are also important and that can be really helpful. So I always, personally in my consultations, I always have a conversation about, what are your thoughts about these medicines? What have you tried already? What are you trying? So I think having a very open dialogue about, what the person with the condition wants. Yeah.
Thank you. There's another question to my far right.
Hi, my question is a two-part question. Do you have a statistic on how many people do not get the right treatment on the right time? And if yes, what is the root cause of that?
So I didn't hear the beginning of that.
So do we have a statistic on the proportion of people not getting the right drug first time? And I mean, the likelihood is probably very high. And that's, we have more and more drugs becoming available. And as Dr. Pink said, they don't even fit on one slide. There's so many. But the structures in the NHS, the way the pathways work, as we've said, you go up the ladder, you start on, your first systemics might be the methotrexate or the cyclosporin. And actually, as Prof was saying in her slide, hopefully in the future, we'll be able to drastically speed up that process, but also hopefully circumnavigate some of those options and get you on the right drug first time earlier. But crucially, the current structures just don't allow us to, we don't have the knowledge to do it, and the current structures don't allow us to do it just yet. But that's the future, and that's the hope.
Yeah. But building on that question and that answer, Catherine, I think we've got the idea from you, and hopefully this is correct, that you want better treatment more quickly. You don't want to wait years and years. And I remember Helen McAteer telling me that something like patients are waiting up to 10 years to get the appropriate treatment because of this kind of stepwise ladder approach to treatment. There is a bit of action within the world of dermatology globally to start try and put pressure on healthcare providers to think differently about this. And I'm thinking here, Catherine, about the International Psoriasis Council. Catherine's secretary of it currently, and their disease severity. Do you want to say something about that and what they're trying to do?
Yes, because I think that actually we had the discussion earlier about this inadequate nomenclature when we talk about mild, moderate and severe disease, because it really is, it's about the impact on the person. And so there's the IPC have come up with this definition that's based on therapy. So in other words, if you have disease of sufficient impact that needs tablets or medicines requiring systemic therapy. So for example, psoriasis happening at high need sites, so high impact sites, so hands and feet and face, so it might be a limited area, or psoriasis that isn't responding to topical therapy. So those are perhaps better descriptors of what we mean by, you know, impactful psoriasis. We need to come up with a different nomenclature, I think.
Question at the back in the middle.
Hello again. I was wondering, with your, Catherine, speaking about the, what was it called, model-informed precision dosing thing, how soon, obviously it's an idealistic at this point, but how soon might you? Because I was thinking it kind of sounds like the thing we have INR for warfarin, like monitoring where that medicine dosage is at and keeping a pretty regular, consistent check. Is it something that...
Yeah, so it's actually therapeutic. So the concept of measuring how much drug is in the body and the right amount for the person, that principle is called therapeutic drug monitoring, and actually that's something we've recommended in our national guidance already. And the limitation is the diagnostics. So we've got good, easily available diagnostics for measuring certain drugs, but not all drugs. The more precise model-informed precision dosing, where that's coming. So this dashboard that we're developing, you know, we've got a target for the end of next year, and it will be open access. So it's something then to ask for. Planned trial results will be really important as well. So there's always the challenge of knowing what to do and then getting it into a health system. And that's, you know, is it going to be commissioned? Is it going to be cost effective? And actually, to your point, one of the things that I learned from that, bringing in the generalized pustular psoriasis drug, the new drug, it's very frustrating. And I think, Julia, you know, because you're an influential person at the top of the NHS, you know, all of our, in the UK, we have all that data. You know, the healthcare records are all joined up, and it's just not being exploited properly. We could better capture the impact of any disease, and in particular psoriasis. So it's really an ask for, you know, at the top to join those health systems together and better capture the impact. And then all of the cost effectiveness would be much better described. And so the drug acquisition costs are tiny, actually. I mean, you know, with the biosimilars now, ustekinumab, it's about £1,000. What is it, the cost for the NHS?
Yeah.
I mean, it's about £1,000.
Yeah.
There's nothing, really. It's just we're not properly describing the impact. So, call to arms, Julia.
Well, I'll just make a comment, then I'll hand over to Jill. I mean, I think we're in incredibly difficult times in the NHS. I hear what you say, and certainly the time that I was clinical lead for NHS England for dermatology, we did make some changes to access, and those of you that have heard me speak at this meeting in previous years, we did introduce patient-initiated follow-up. so that you could re-access services. We've introduced advice and guidance as the front door to dermatology services, which means that your GP should be able to send in pictures of your psoriasis, not ideal if it's in sensitive areas. You send in pictures with the history, and you should be prioritised appropriately to a clinic. And so we have tried to use of teledermatology. There are a lot of initiatives that we have tried to put forward, but remember, there are lots and lots of other specialties. There are lots and lots of other priorities that the government has. And I'm not there now so much, but I think data is power. And the more data we have, and the patient voice actually will be much more listened to. And we are moving into the digital age. So we have to embrace everything that you've been talking about today, whether we like it or not, apps, etc. And I think a lot of what we've spoken about today, as an association, we need to be lobbying. And there are ways that we can lobby for that.
Well, the great thing is, of course, is that, as Catherine said, we are in alignment with what the Secretary of State is wanting to do. And everything, actually, not only is it about better care, but it's cheaper. It will be cheaper in the short and medium term and long term.
Hi, thank you. I just wanted to hark back to the MySkin study, and the two main kind of triggers for onset and worsening of psoriasis were stress. And we've talked a lot about different treatments, medical treatments. From an NHS perspective, looking at the psychological support that we give to people with psoriasis, how can we move that forward so that is part and parcel of the treatment plan for people with psoriasis?
Completely agree. Lucy, do you want to go first on that?
I mean, I agree. There's much more that needs to be done, and I think that's been recognised. It was recognised in the All-Party Parliamentary Group for Skin report in 2020, so that's a bad year to release a report. But it is worth knowing that there are sort of services that you can access today. So if you Google NHS talking therapies, you can refer yourself to CBT, which is kind of like the sort of open door access to mental health support in the NHS. If you don't have access to that in your local area, Changing Faces are also offer some counselling services as well, and that's for anybody with a visible difference. So that includes psoriasis, but actually anything else as well. So those are two things that everybody's got access to. And then there are some dermatology services, but really only a few, that also then have access to a psychologist. But again, there might be different parameters as to who gets to see them, because all of these services are so much in demand.
Lucy, in our service, as I said at the beginning, you're the one who often is the first to hear from a patient if they've got a problem. Would you agree with the results of the survey that the triggers are in that order, or would you put stress higher up the list?
Yeah, no, I agree. Yeah. And sometimes it's very often people will connect it to certain events in their life as well. Yeah.
Okay. Question over here.
Something that we've heard throughout today and every day really is that one of the main goals or aims of treatment is to clear the skin. I just wondered, from your stance of a medical stance, why is it that clear skin is the main thing that you want to achieve? Is it because we'll say if there's clear skin, that's an indication that the root cause, the internal issue is at bay and that it's been controlled? Or is there another reason behind why clear skin is the main goal or aim of treatment?
Well, that came from the patient community, that as a goal, really. So that was that's why that goal has become the kind of thing to go for. You're asking an interesting question, maybe also though, about what are these drugs doing? Are they putting the disease properly into remission? You know, when people talk about disease, disease remission on drug, i.e. clear skin, and then clear skin off drug as sort of different things, and this idea that maybe earlier intervention, if you get completely clear skin, you may actually be able to reset the disease to the pre-disease state. I mean, there has even been a psoriasis gene to clinic thing, people were talking about cure, and I think you will never you can't take away your genetic innate susceptibility to that condition, but you could perhaps reset the disease. And that's where, say, Luke's work's really important. So what we see on the skin, clear skin, what does that look like molecularly? Is it just suppressed, or has it actually gone into deep remission? Could we stop the drug? And that is really the focus at the moment, because clearly, yeah. So to answer your question in a short way, clear skin is what people with psoriasis have said they want.
I wondered if that was it, because as an advocate, a message that I try to promote is that I think one of our main issues is this link or connection between happiness and clear skin. And for so long in my life, I went that when my skin wasn't clear, I was not happy. And it took me a long time to shift that in my head. And now I'm very proud of the markings on my skin. I think if more people were very happy and proud to have the marks. And I do know that there's times when they can be quite painful and all other issues like that. So that's why I just asked, there's times when they're not painful, but it's the unsightliness that people want to get rid of. So that's why I was asking if the aim is for a medical reason, or if it's because the patient wants the clear skin. So
yeah,
that's
I
where
think
my
at the moment
motivation
there's no medical reason to say you need clear skin. It's usually from a patient goal. But your point is very important. You know, what does, then that's a conversation you should one hopefully always has with your healthcare provider. You know, what are you hoping to get out of the treatment? Absolutely, yeah.
Yeah, I mean, just to add on to that, I completely agree. I mean, there's a good correlation between clear skin and good quality of life according to patient-related outcomes. So that's kind of why it's used. I mean, if you're treating diabetes, you check the blood sugar because you want to check the blood sugar before they get symptoms from the diabetes. We just don't have that at the moment. So the best marker that we're doing the right treatment is what the skin looks like at this moment in time. But all the work that's going on, Luke's doing and others, is to see, actually, can we be measuring something else so that we don't give the patients any more medicine they do, but they're happy. And that's right. Here first, then Julia.
Hi, question about high blood pressure or any other kind of comorbidity, actually, but specifically for myself, I'll say, and since it is a very common comorbidity for people with psoriasis, is there any sort of recommendations on when to take these medications? If you're taking tablets, for example, for psoriasis and tablets for your hypertension, time of day. There is a significant amount of study that says that blood pressure medication is more effective taken at night, for example.
Yeah, I think obviously it will depend fundamentally on the different combination. There's however many different anti-high blood pressure tablets and however many different tablets for psoriasis. So every single one might interact differently. In general, you just want to be taking them regularly. Remember to take them. So it's probably far more about routine and working out what works best for you so you don't forget them, so you have your blood pressure as best controlled as it can be, and likewise your psoriasis routine, you're not missing tablets. But in terms of the specifics, you'd have to look at, it would be a conversation about the exact two drugs that you're talking about.
Yeah,
but
it just
in general, I don't think there's not like massive big things. It's routine. Whatever works for you, that means that both conditions are going to be the best controlled they can be. It works with your lifestyle, it works with whatever's going on, that's most important.
Even if you take it regularly, it's the interaction between the medications, I guess is more my question. Like there are certain things that you shouldn't take if you're on antihypertensives, for example, or something
It very much depends on what the psoriasis medication that you're talking about. But in the main, the biologic treatments do not interact with tablets. So that is one big advantage. But it is very drug specific. So yeah.
I mean, it's true given that often some patients with psoriasis might have lots of comorbidities. So that means they may be on lots of drugs. So, it's the doctor's responsibility to make sure there's no interactions before they
some blood pressure medicines, historically, we've said make psoriasis worse, beta blockers, for example. But I think, get advice.
Okay. Julia.
So I just wanted to come back to your point about happiness and clear skin and the relationship. I remember 20 years ago, we opened our day treatment unit in St Albans, and the first patient was covered in psoriasis, and we took some time and we got him clear, and he was very happy. And then his psoriasis recurred within 3 months. And he was beside himself. He said, "Why did you ever get me clear? I was much happier living with my psoriasis. You've now cleared me, but it's been such a huge investment in time and effort." And I think that your perspective is not taken account of enough. I think we do need to think about that, and I think it's a really thoughtful point. What I wanted to ask about, and it's a bit left field, I was at a meeting where EMDR was used for psoriasis. If for those of you who don't know, that's eye movement desensitization and reprocessing, which is used for post-traumatic stress disorder. I was at a meeting where it was used with 9 patients with psoriasis and all 9 got better. And I wondered if there were you had any knowledge of this, any experience, or whether there were any studies.
So got better from a psychological perspective, or
Their psoriasis got better.
The skin.
Yeah, it got better. So basically, big stress,
Yeah.
big psoriasis, EMDR, psoriasis went away, was what the story was.
Yeah.
But, you know, this was a small
Lucy,
series.
any experience of this?
Our psychologist, Mark, has tried that with patients in order to help them get onto treatment, but I'm not sure of it having any direct effect on their psoriasis. But the problem is it's quite time intensive.
Yeah.
And, you know, for some people, it's not something they would want to consider. But, yeah, I know that our psychologist, Mark, has used it, but it's been as a way to get somebody onto treatment rather than manage their psoriasis.
I mean, it's an evidence-based intervention for PTSD. As far as I know, there's no evidence specifically for psoriasis. But that's interesting. I mean, that's interesting. It's worth, you know, looking at. Yeah.
Right, any final burning questions? Yes, is the answer.
I'm just curious about tattoos. I mean, more people seem to have tattoos, and I kind of wonder if they get psoriasis, it's not going to be very easy, I'd assume, for that to be identified, the nature of it, and also whether having tattoos might trigger psoriasis.
Oh, well, it can do in some people, yes. I mean, some of you might have experienced if you get scratches or scars, you can get psoriasis in the scar, and you can do that with tattooing. And there are some pigments that are worse than others. It's not common, but it does happen, and it can be challenging to treat. But it's not common, but it does occur. Any other comments? Lady at the back in the middle. I think this might actually be the very last one. With matching tops.
It's been around a long time. No, just going back to Julia's point, because in the history of my psoriasis, at very stressful times, I've had clear skin, and vice versa. And I just wondered if the disease itself would come and go. I've discussed this many times with people. Anyway, we're like a lot of things. Does that make sense, the question I'm asking?
Yeah. You mean psoriasis flaring with certain life events going on, clearing and then coming back?
Anyway, if life was just normal.
Well, the periodicity, everyone who has psoriasis, their psoriasis is different. Some people it's very static, stable, others it's waxing and waning. Sometimes it can disappear for a long time and then come back. Everyone is very different. And you see this across all long-term conditions, not just psoriasis, you see it with arthritis, everything. So it's very difficult to generalise.
But
if you find it...
Your point also that it's just coincidence that people cite stress as a trigger, but actually it would have happened anyway.
Yeah. Would have happened anyway, yes.
Yeah, so absolutely right. And that's why these longitudinal studies like My Skin, to get that granularity and prospectively collecting it. Because, of course, there's a recall bias as well, isn't there? You know, your psoriasis flares up or your condition flares up, and then you think, oh, yeah, but I've been really stressed. But maybe, you know, so I think your point is very well taken. That's why the longitudinal prospective collection is so important.
Yeah, it's only from experience.
Yeah. Right, well, thank you very much. And thank you very much, panellists, for your stimulating answers. Over to Julie.